I guess one of the more serious side effects to dial down on, and I'd love to get your take on your management, because I think it varies it can vary from patient to patient in one institution and one investigator to the next. But to me is the cardiac side effects. And so, the most prominent, of course, is atrial fibrillation and how to manage that. I mean, it's not only, do you stop the drug and start them on another drug, but if you keep them on the drug, do you have to keep them on anticoagulation? And I usually do this in collaboration with a cardiologist, and the cardiologist will tell me, well, the person's CHAD score is this, so they're very high risk for stroke, and you really need to keep them on anticoagulation. On other instances, no, you can stop the anticoagulation. I've been tended to now that we have acalabrutinib, if someone had atrial fibrillation on ibrutinib, I've generally tried to switch them off to acalabrutinib and then work on whether we need the anticoagulation. And of course, you also have to be a little bit careful about if there's any drug-drug interactions with some of the antiarrhythmic drugs that sometimes people are placed on. So working on that. What's your take, Jan? Have you do you do something radically different to that, or is that similar to what you're doing in Houston?
I think that's a perfect summary. I totally agree with all the points you're making. I think for a while we've been saying we need guidelines and strict guidelines how to manage cardiac side effects and atrial fibrillation with ibrutinib. But what you're describing is exactly what we are doing. And it is such a case-by-case decision. And at the time when we didn't have acalabrutinib, we managed patients with the cardiologist on a case-by-case management plan to see if patients can be converted back to sinus rhythm. And then we reintroduced usually the BTK inhibitor, usually at a lower dose, and we escalate it if necessary. And that sometimes works, but it doesn't always work. But I think, it's a case-by-case decision when patients are co-managed with the cardiologist. Anticoagulation is discussed. They are usually trying to convert them back to sinus rhythm if possible. And now we have acalabrutinib, so I think it's absolutely reasonable to bring it up to the patient to say, well, we have this other agent which is more selective, which may have less cardiac side effects. It's not proven. Early data show that maybe the frequency of atrial fibrillation is lower, but that's really early days, and we have much longer follow-up with the ibrutinib trials. So I'm not advertising acalabrutinib too much in that sense, because the randomized study, and that's the reason why they are doing this randomized study, is to have stronger data, but it's a good alternative. And if patients are interested, then I switch them over. Otherwise, if they have high affinity and otherwise benefited a lot from ibrutinib, we can try to keep them on that. But it's good to have more options and management of these side effects. It's a case-by-case decision. Is that your read on the data too, or are you confident that the cardiac side effects with acalabrutinib are less? How would you read those data?
I'm not confident that the cardiac side effects are less. The only thing that gives me pause in that whole thing is that, well, the trials are often very different, so cross-trial comparisons are difficult. However, there is a trial in Waldenstrom's where zanubrutinib, which of course is not indicated in CLL, but zanubrutinib was compared head-to-head, and they have released outcomes, not yet published, but they've released the outcomes, and the atrial fibrillation rate was a tiny fraction when people who got zanubrutinib compared to the patients who got ibrutinib. And so at least, that's a randomized trial, different disease, but a randomized trial. And so, so it was striking. It was striking. So I bet there is something to it, but I'm not, I'm not sure we can quantify it yet. But at least that makes me think if someone has a side effect with ibrutinib, then it gives me, well, we should definitely try acalabrutinib. And I don't think that having had ibrutinib decreases worsens the outcomes for someone if they then go on and get acalabrutinib. So I'm comfortable with that segue. I'm also comfortable with starting people on acalabrutinib, and again, it has to do with whether they want a twice-a-day drug or once-a-day drug. If they already have a risk of some of these things, then I may or might not go to acalabrutinib. And so I think it really has to be individualized. I don't have one BTK inhibitor I use for all patients. I use different ones for different people for all that.